Mamta is the next presenter. She will be
surface staining. The normal ocular surface does not get stained because of presence of glycocalyx and the corneal epithelium. They are very tightly adhered. It's automatically going right. The superficial corneal epithelial layers, they are tightly adhered and it does not allow the dye to go inside. And as we go deeper into the corneal epithelium, the junction become more permeable due to presence of aquaporins and gap junction, which allow the fluid and the solute to pass from one cell to another. And that is precisely the reason that once the superficial epithelium, that layer is breached, the dye, if at all it enters, it can diffuse to the surrounding cell. And that is why we get to see a picture which was quite well defined in the beginning that can give a fuzzy appearance if we examine the same patient after 4-5 minutes. Commonly we use one of these, either fluorescent, Lissamine green or rose bengal. If we talk about visibility of corneal pathology, then we need to have a dye which can be easily seen against the dark brown iris. So the obvious choice here is fluorescent, but a fluorescent dye, especially if used in higher concentration, it tends to form an opaque tear film. So if you want to examine punctate staining, we need to wait for a while and let the dye concentration go down. For conjunctival pathology against the white background of sclera, it's either rose bengal or Lissamine green, and they both stain dead and devitalized tissue or any part of the ocular surface not coated with the mucin. For rose bengal, better visibility, we need to use the green filter. For Lissamine green, it's the red filter. But as rose bengal causes stinging sensation and it is not very comfortable for the patient, so mainly we have shifted to Lissamine green. But if we need to use one dye for both conjunctiva and cornea and we are using fluorescent, then mainly we need to use yellow filter for seeing the conjunctival pathology. Like this was a case of conjunctival gerosis bitot spot, quite easily visible with the yellow filter. There is something called quenching phenomenon of the fluorescent dye. As the dye concentration keeps on, we keep on increasing. The property of fluorescence also increases, but only up to a certain extent. Beyond that, the dye starts appearing black. So if we are using a very low concentration of fluorescent or if we are using a very high concentration, probably we will not be able to see the proper staining pattern. Normally, it is the excess of dye which is a problem with fluorescent, and it is the lesser dye which is a problem with, especially with rose bengal and for Lissamine green also. So what I do, I prefer to use this moxifloxacin eye drop because sterile saline it is a little, not very practical for me. So if I am putting it on the fluorescent, I prefer to put the drop a little above this stained area. So by the time it comes down, the volume becomes a little lesser, and then I gently shake it off. And as I said, it is the lesser dye which is a problem. So in Lissamine green and rose bengal, particularly in rose bengal, I prefer to use 2 strips together, rub them, wait for a while, let it soak with the solution, dilutic solution, and then only use it on the patient. We can use it either in the on the upper bulbar conjunctiva or lower. Especially in dry eye patient, we prefer to use it on the upper bulbar conjunctiva. So if you are using a fluorescent dye, always start with the maximum available illumination because we are using a cobalt blue filter. With higher illumination, RB and LG are like those spots are very, we do not get optimum visualization there. So starts with moderate and then go towards the higher one. Then assessment can be done immediately after using the dye or between 1 and 4 minutes depending on the case also. For example, if we are trying to see signals, it's better to do immediate assessment. Then there are various applications. We all know if we talk about use to, it talks about having more than 5 corneal stain and more than 9 conjunctival stain as one of the diagnostic steps. There are different grading patterns, and this has been recommended by the AIOC Society of Dry Eye, and it talks about different pattern of tear breakup, which talks about different type of dry eye. Marks line. In cases of MGD, there is this anterior shifting of marks line. We all know other applications, Seattle's tests, in graph, in OSSN, we can use either rose bengal, toluidine blue and methylene blue. Out of these, methylene blue has got highest sensitivity and specificity. These are different stain, and depending on the location of staining also, we get an idea of what kind of pathology we are dealing with. If it is superior corneal, probably there is this allergic or vernal. Inferior bulbar, we get to see preservative or medication-induced toxicity. Then contact lens practice, these are all very common. This is not exactly corneal surface. This was actually one of the residents who by mistake injected the dye in the corneal stroma. This trypan blue, we can see the bluish hue here. This is 10 days after the surgery. We can clearly see descemet tear here or lost descemet portion here, but the dye disappeared without leaving any effect of it. With this, I would like to conclude. Thank you so much.